Hello, I'm Mabel Jung, and you're watching the World Healthcare Congress Interview Zone. I'm so pleased to welcome Omar Ishrak, CEO and Chairman of Medtronic. So nice to see you today.
Nice to see you too. Thank you.
Well, there seems to be a lot happening right in Minnesota where Medtronic is based. Are you creating a global hub there for medical innovations, if you will?
Well, you know, one already exists because there are a number of healthcare companies there, many in fact, and there's quite a hub for life sciences. In addition to that, we have both in Mayo Clinic as well as other groups within Minnesota and in Minneapolis itself, renowned healthcare providers. So between all of us, there appears to be a critical mass of capability. Frankly, this has just happened, I mean, organically. And I think only recently have we started talking about partnerships in which providers and device manufacturers work together to drive healthcare forward.
Now, are there other plans to collaborate with other hospital groups throughout the world for Medtronic? There seems to be a lot of activity in the emerging markets, if you will, to become better prepared to meet the health needs in future years.
Yes, of course. In emerging markets, the collaboration models are either with major hospital systems, and that's most prominent in India, where you've got some really well-known hospital systems which are providing fairly good care, addressing a large population base, and they're very focused on expanding coverage. And Medtronic is working very closely with many of them. Apollo Hospitals being one, Fortis Healthcare being another, Max Hospitals being another. So there's a series of hospitals in private providers in India we're working with. The same is true in the Middle East. Now the other model is working with governments, because in many instances the government, in government-run healthcare systems, we're trying to work with governments to identify specific needs of that very specific population. A recent example was in Kazakhstan, where the need for diabetes care amongst juveniles for type 1 diabetics was articulated and clearly demonstrated, and through that we're working now together with the government to actually deploy care in that country. So that is an example of where we can go to a government in a government-run healthcare system, sort of identify real needs of that population and work with them, not only to provide the product, but actually to break the barriers down of providing care, training physicians, training health workers, and really working together with the government to make sure that the care reaches their population.
And some of the areas that you're referring to have very vast rural areas that have very difficult challenges to bring the need to the care. So are you working in the area of e-health, for instance, too, to provide services that would help people that just don't have easy access to care?
Yeah, I think that's a problem by itself, and that exists in all countries in the emerging world, some more than others. The example that I gave earlier was in a much more specific area where a need is identified and the therapy delivered, irrespective of whether it's rural or not. Now, the rural problem, as you point out, is what we call the underserved market, which is one of the largest population bases in the world, which don't have access to care. For that segment of the population, we're trying to identify specific ecosystems to treat certain conditions, and then work on developing that ecosystem in its entirety, and then try to see how we can move the needle. And we're also working with different kinds of partners, partners like HMRI in India, or Grameen themselves, or others who really have access to the underserved population in some form. And together with them, first try to isolate, well, what disease do we want to address? and it's fairly narrow. It's a particular form of cardiovascular disease as opposed to all of cardiovascular. It has to be as narrow as that. And then see, well, what's the ecosystem through which such a solution can be sustainable? What are the models of ecosystems so that such solutions can be developed? And then figure out together with them, well, how do we do it, and then drive pilots and so on and so forth, and develop technology specific for those needs. And telemedicine is clearly one capability that almost certainly needs to be developed, but that's not the only thing.
Certainly, it sounds like there are a wide number of opportunities available overseas. Now, to bring Medtronic back home to the U.S., what are you most inspired and excited about here?
Well, in the U.S., you know, the Affordable Care Act has triggered a thinking and a movement around greater collaboration between the different stakeholders to improve quality and lower cost. And we are very engaged with different stakeholders to run pilots through which the quality cost equation can be quantified in certain areas, and then based on that evidence scale those solutions across a broad sphere of patients. I think that this movement is only starting. I think it's essential to attack this in a granular fashion and take on areas which are less complex first and scale them, because even in those areas we think a lot better healthcare can be provided, and then gradually move up the chain to attack more and more complex problems, some of you know, long-term disease management, and many other areas. So I think in the U.S. This energy towards improving quality and lowered cost, although may seem frustrating at times, I think actually is beginning to gain traction in terms of people really trying different things.
Right. Okay. Well, thank you so much for your time today.
Thank you.
I appreciate you stopping by.
Thank you.
I'm Mabel Zhang. Thanks for watching.